Hello, everyone. Welcome to week two. Hope you all have reviewed your syllabus and all the things, and I have corrected and given you all the points that you deserve because I need to review my questions and I need to review them before I post them. That would probably be helpful, but now we should be good. We're going to get into it. This is going to be the start of how we get the class going proper. So the way that the class usually goes is I start out with a little bit of a preamble of like stuff just to kind of either talk about the class or talk about things in my life or whatever, just to, be kind of interesting, I guess. And then I'll give you a big idea, so a concept or a thought to hold as we go throughout all of our lecturing for the week, and then that's kind of it. So that's how this will go. Again, my lectures are, you're going to get probably 40 to 45 minutes of content. For instance, I've got 25 slides, so we'll see how it goes. But that's the class. So welcome. I was in Chicago over the weekend. One of my buddies is getting married, and so we went to go celebrate him. Got to see Wrigley Field for the first time, which was pretty cool. Very different, but very cool. Unfortunately, the Cubs won because I'm a Reds fan and I want to see the Cubs lose. But such it goes. So Chicago was cool. Had a good time. I encourage you to go to Chicago if you ever get a chance. It's a cool little city with neat stuff to do. So here is your big idea. I've actually been to Chicago twice in the last 2 months. I went last month to go to a Blackpink concert, Korean pop band Blackpink concert, and then, the bachelor party. So anyway, here's your big idea. Drug use is a human behavior and does not derive from an individual's moral compass. The substances that we will discuss are simply chemicals. It's all that they are, okay, that have an impact on our nervous system, okay? How we choose to react to the person using the substance says more about us than it does about them. We'll talk about concepts called transference and countertransference at some point during the course of our time together. But countertransference is a really big deal, especially here in working with people who struggle with substance use disorders, okay? And that will make more sense as we get going down the course of this semester. I'll explain what that is. So remember that I said that when we get there. Now, with going back to what I just said about simply chemicals that have an impact on our nervous system, okay? That's hard sometimes for us to really think about, right? So when I say the word, before I get there, let's just play with that thought a little bit. I'm going to give you a scenario. And what I want you to do is I want you to just kind of sit with and how you feel about it, what you think about it, and then we'll move forward. Okay, so I'm just going to give you a little bit of a thought experiment. Okay, patient presents excessively jittery, complaining of racing thoughts, anxiety, mood instability, and powerful persistent headache. Patient was irritable and did not wish to talk much during the clinical interview. Patient states that they have recently been under the influence of a substance that they either use once in the morning or numerous times throughout the day. Patient states that they feel as though, not thought, though, this substance consumes their thoughts and that they have a difficult time functioning in the absence of the substance. Patient reports that once they have their substance of use, they feel calmer, clearer, more relaxed, and they have lots of energy. Patient states that they initially started using a small amount of the substance, but have found that over time their use has increased and now they feel as though they are using excessively. Patient commented that their sleep patterns are disrupted due to the use of this substance. Numerous attempts at discontinuing the substance have been made, though to little or no success. Patient complains of severe withdrawal symptoms, which brings them into the office today. Okay, I want you to sit with that for just a second. What could this substance be? It sounds pretty serious, right? I mean, they're using multiple times throughout, maybe once a day, which means they're having to use kind of a lot in the morning, or numerous times throughout the day to kind of keep things going. That it consumes their thoughts. They're all they're thinking about, right? And once they have it, they feel calm, back to functioning, right? But then they started using a small amount, but then over time found that their use increased and now they have to use excessively. Okay. Numerous attempts at discontinuing the substance have been made, though no success. Complains of withdrawal symptoms. What could it be? What do you think? Heroin? Cocaine? Meth? Boy, it could be anything, right? Coffee. I'm referring to coffee. Sorry if this is any of you, Little Miss Mocha Addict, iced mocha addict. Coffee, right? Now, as I'm presenting that to you, maybe the worst impulses came of like, oh, that's got to be fentanyl, right? But that's coffee. As I typed that out, I was thinking of what we say about coffee. Now, if you went to those places, then that's kind of my point. I'm not saying that, oh my gosh, you're a bad person for thinking this. I'm just saying that's a bias that can show up when you're doing this work. And I've seen it a lot over my career. I've seen it to where I would have coworkers who, and I know many of you wrote in your introductions that you are in recovery, actively in recovery. And listen, that's amazing. I wrote many of you, I think all of you that mentioned that. One day of recovery is a milestone, and to string several of those together is remarkable, right? One of the things, though, is that you still have work on yourself to do, because one of the biases that sometimes comes to play is that, well, the thing that worked for me will work for someone else, or the way that I look at myself as it relates to my past, somebody else is going to look at the same way. And that's not necessarily true. And so I have seen some of the most, and I'm not saying this about all of them, I'm just saying this is more anecdotal. I've seen some of the harshest people on persons in recovery are other persons in recovery because of their own stuff, their own shame, their own guilt, the things that they have experienced as a result of their substance use. Okay. Now, it's not to say it's all of them. I've seen some of the best. So it's a little bit of a mix of both. But what I'm bringing up is that we really have to check ourselves as we're doing this work. How do I feel about persons struggling with addiction? How do I feel about addiction overall? And how can I work through some of that to get to a better place if you are kind of struggling with that? Okay. We'll talk about models of addiction today. So hopefully that'll clarify a little bit of what I'm talking about. So here's how the American Society of Addiction Medicine looks at addiction. Addiction is a primary chronic disease of brain reward, motivation, memory, and related circuitry. Dysfunction in these circuits leads to characteristic biological, psychological, social, and spiritual manifestations. This is reflected in an individual pathologically pursuing reward and or relief by substance use and other behaviors. Now, oftentimes people start out using, let me rephrase that. When you're in career day in elementary school or middle school, I highly doubt that any of your classmates said, when I want to grow up, I want to be an addict or a person struggling with addiction. No one really does that. So addiction is not something that someone sets out to have. Addiction is something that happens as a result of other stuff, right? So it starts out as a pleasure-seeking activity, right? It starts out as something to either, I just want to feel better, right? So the avoidance of pain or the experience of pleasure. Over time, it becomes something habitual because sometimes it's to re-experience that high, but as we get kind of deeper into addiction, it's to not be sick. In many ways, I enjoy drinking coffee, but I really don't like the coffee headache that comes when I don't have my coffee in time, right? And I'm sure many of you can experience that as well. Now, if I'm just worried about a headache and I'm a little moody and I just don't feel good, right? Now, if we're talking about someone that's struggling with heroin addiction or fentanyl addiction, opiate withdrawal, those are very severe. Like we're talking sweats, shakes, can't function, throwing up, jittery, racing thoughts, and I'll have stories about that as we get into medication assisted treatment, the section on medication assisted treatment. But like those consequences are very severe. And so the desire to use in many ways at first starts out as, oh boy, this is great. But eventually I just don't want to be sick. And that cycle is what gets people caught, is because the consequences for not using are so incredible. It's also why fentanyl kind of got to be fentanyl and why people are searching it and we're doing derivatives, is because when you feel like when we started out with just heroin, that was one thing that was dangerous enough. But now the power that comes from a fentanyl high is almost 10, 15, 20, maybe even 100 times higher than heroin. Well, when you feel that, you want more of that, and it didn't kill you. So you start seeking that more, and then you want more, 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 and that feels good. So now I want that, but that's my new standard now, right? We'll talk more about that as we progress through, but I'm just giving you an example of what it's about. It's not just about somebody's moral failing, there's more to it. Okay. Now, here are some models of addiction that we're going to talk about. Okay. So the first one is the medical model, which is the American Medical Association's way that they look at it. Addiction is a disease because of the changes in the brain that occur as a substance continues to be used over time. Okay. So the medical model would say it's a brain addiction. Okay. The biological model says that addiction is primarily a result of our genetic makeup, meaning that if your parents struggled with addiction or your grandparents struggle with addiction, you too will struggle with addiction. Okay. We'll talk about some of the difficulties with these once I name them all. We'll come back to them. Okay. The social model, which is addiction, is heavily influenced by the culture and the environment by which we are exposed. So, your parents may not have struggled with addiction, but if you get caught up in the wrong crowd or you get caught up in a crowd that is using, you will be influenced socially towards some of this. It's a evolutionary trait that we are designed to be in a group, right? So many of you are introverts. I am an introvert. We kind of, our social battery drains very quickly. And so I've known that for a long time, but that was especially true in Chicago. I'm just want to go home. So, however, we do need people, despite some of our introvertedness telling us that we don't. So because of that need for social connection, social interaction, safety in a group, right? We may join along just so we can feel safe. And that's really what it's about. I want to feel love. I want to feel belonging. I want to feel connected. Okay. Reinforcement model, which is that addiction is a learned behavior that is selected for over time. And then there's the biopsychosocial model, which is a little bit of all of the above. Okay. So a little bit of all of the above. And then there's the Department of Corrections model, or the DOC model, which is that people struggling with addiction do not know right from wrong. That's pretty much out. That is not, it's still out there, but we don't really give a ton of audience to it. Basically it really doesn't have any clinical relevance anymore. That in order for someone to overcome addiction, they just need to be shown tough love, or they need to be broken down to learn new moral. That's gone. I mean, that's pretty well gone. And I can just tell you that from personal experience. Every patient that I've worked with is a good person, has goodness inside of them. It's just this addiction kind of like overrides some of that, and that desire to get that high or to not be sick can lead them to doing some things that they're not necessarily proud of. Doesn't know that they don't know right from wrong. It just means that sometimes that addiction can override their better thinking. Now, some of these other things. Honestly, you can kind of pick and choose what you think. Most of us will go with biopsychosocial model, which is kind of the catch-all, and that's the easy one to go to. But any of these are valid except for the DOC model, right? The medical model, I mean, as I'm going to show you, I'll show you brain scans eventually during the course of our time together. But yeah, the brain changes, and the things that were activated aren't, or are overly activated and overly stimulated, and some of those things can stay on. So with methamphetamine use, when you look at the brain of somebody that is struggled with methamphetamine addiction, it looks remarkably similar to someone that's struggling with schizophrenia. The same parts of their brain light up on a PET scan. So like you can see that stuff. It's crazy. They look, and I'll show you as we move forward, but like they look remarkably similar, right? So those are things to keep in mind that, okay, yeah, there are changes in the brain that does happen due to our brain's thing of neuroplasticity, to where it fundamentally can change a person. Okay. And many of you, and I'm going to talk about that as we get in this lecture at the end. Okay. For me, and I'm sure for many of you as well. The biological model. So the thing with our parents, if you just have one parent who struggled with addiction, you have a 30% greater likelihood of developing an addiction yourself, okay? Or struggling with addiction yourself. So you just need one parent, okay? Both, it's not really clinically significant, but you just need one, okay? It's not a guarantee, it's just a 30% greater likelihood. Okay? Good so far? All right, let's move on. So we're going to have four main categories by which we label these substances, okay? We're going to have stimulants, which obviously you can probably guess what those are. Those are your cocaines, you know, the things that are going to bring you up, cocaines, methamphetamines, depending on your preference with what methamphetamines do, but we consider it a stimulant, okay? You have your depressants. Now, depressant does not mean sad, okay? Depressant looks at, all of these look at central nervous system. What does it do to your central nervous system? So your depressants. So now we're talking opiates, right? Opiates slow things down. They depress the system, okay? So when somebody takes an opiate, their heart rate slows, their blood pressure lowers, like that's what opiates do. They slow things down. Now, so does alcohol. Alcohol's in its own class to a certain degree, but technically it's a depressant. It's going to slow things down, even though when you drink it, you feel like there's the initial sort of euphoria that comes with drinking, but eventually it does turn into a depressant. Then you've got your hallucinogens or your psychedelics. So this is going to be your marijuanas. This is going to be your LSDs. This is going to be your acid. This is going to be your mushrooms. Magic mushrooms with psilocybin in them. And that's what they're classified as. Okay, so those are your four main categories we're going to look at. So one of the things to remember is our American society has a really hard time with addiction. We just really struggle with it, going back to that moral model. And we're going to talk more about this next week, about how our drug laws are rated in classism and racism. But this is from the 1930s, okay? This is how we looked at addiction. Okay, it's weed from the devil's garden. So one of the things that we do differently is that we look at it as a moral failing, whereas other parts of the world see it as a health crisis, which it is. It's a health condition, but it's the only health condition in America that we get mad at somebody for having. So you're not going to look at somebody and say, oh, they're a lupus, but we do say, oh, you're an addict. And I talked about that language last week. So we have to really be careful with how do we view people who struggle with addiction. Because it's these little things that turn it into a shameful thing. And it's not. It's a personal struggle that someone has that can be overcome with support. We'll talk more about the support throughout the course of this semester. Just because someone is using a drug does not necessarily mean that they have a problem with the drug. Now, that may seem counterintuitive at first. And I also bring up this abuse, misuse, dependence. We used to have two different definitions, substance abuse and substance dependence. Now we don't have that. We just have substance use disorder with varying degrees. And we'll talk about that next slide, actually. So we don't say substance abuse. We don't say substance chemical dependence. We just say substance use disorder. And that goes for all substances. We go by what's called the DSM-5, TR, text revision. And before that, it was the DSM-4. Obviously, because you can count backwards, I assume. And the DSM-4 had a designation for each individual substance. And then in the DSM-5, they came in and said, nope, we're just going to lump it all into one. Okay? So this may be a little bit counterintuitive at first, but let me process it with you. Okay? Let's talk about Jane. So Jane goes to college. And she is in Sigma, Chi, Kappa, Phi, Omega, Chi, Delta, Kappa, whatever, Omicron, whatever, sorority, all the letters. And during the week, she's good. But on the weekends, all she thinks about are where the mixer is going to be. So she's going to Sigma Chi. She's going to all of these other fraternities and different sorority things and just getting absolutely plastered on the weekends. Blackout drunk, just having the best time, throwing up. You know, sometimes she got behind the wheel of a car, but that's not that big a deal. It was just on campus. What's the big deal? Not hurting anybody. just blowing her money. You know, she works during the week at PetSmart, and then on the weekend just goes belligerent. Um, but during the week, she's fine. No issues at all. Okay. Now, let's think about Joe. Joe is a 45-year-old um, man who works a construction job, and he works hard, and he comes home, and every night he has 4 to 6 beers every single night. No other health issues. He's doing pretty well financially, so he can afford it. He's not missing out on any work, and he's not missing out on his kids. Health generally okay. Could be better, but who amongst us couldn't it be? But every single night he comes home and he drinks 4 to 6 beers. Okay. Sometimes on the weekends he'll get a little wild and drink, 8 to 12, but nothing to where he loses control. Of those two, which one would you say has a substance use problem? Jane? Joe? Both? Neither? It's interesting to think about. I'm not going to give you the answer because I want you to think about it. But if they're coming into your office, how do you determine what it is? Well, that's what this is for. Okay? So these are the diagnostic criteria for substance use disorders. We have 11 of them, technically 9 of them, but also 11 of them. So it depends on what you're facing, right? So these are the things that we look at to determine, does someone have a substance use disorder? Okay. Number 1, taking the substance in larger amounts or for longer than you meant to. Okay. So it could be that you were taking it for long. You started with 1 beer, but now you're drinking 12 beers. Okay. Or you're drinking 2 beers over years of time. Okay. So either of those would count. Wanting to cut down or stop, but not managing to do so. So numerous attempts to quit. Spending a lot of time getting, using, or recovering from the substance. So I'm spending an inordinate amount of time going around and trying to make sure that I have my substance to the point that it interrupts my day. Okay. Or I'm drinking so much that I'm having terrible hangovers and it's having an impact on me the following day. Cravings or urges to use the substance. So, whenever I'm not using, I'm thinking about it, or I've got the itch to have it. Not managing to do what you should at home, work, or school because of substance use. So you're deficient on your job. Continuing to use even when it causes problems in relationships. So a friend or a loved one or a coworker has said, hey, you probably need to quit. And it's actually, you get mad at them. You'll have a lot of fights and it's problematic. Okay. Giving up on social, occupational, or recreational activities because of substance use. Like you used to play in a men's basketball league, but now you're using so much that you can't, or you used to be involved in the PTA, but now you can't. Okay. Using substances again and again, even when it puts you in danger. Okay. So getting behind the wheel of a car, continuing to use, even if you have a physical or psychological problem that have been caused or made worse. So let's say I have cirrhosis of the liver and I know that, but I'm still using. Okay. Now, these last two depend on what you're seeing. So needing more of the substance to get the effect you want, that's tolerance. Okay. I need more and more and more. And then the development of withdrawal symptoms, which can be relieved by taking more of the substance. So the only exception is prescribed drugs. Okay. So this is usually like your Xanax or your Suboxone. So Xanax is a nerve pill, otherwise known as Alprazolam. It's an anti-anxiety pill, or a Suboxone or a methadone, but only if it's under the care of a doctor. If you're getting Suboxone or Subutex or methadone or Xanax off the street, that doesn't count. It's this, right? So it's only if it's under the supervision of a prescriber. Okay. So 2 or 3 of these, we would say mild substance use disorder. 4 to 5, we would say moderate, and 6 or more would be severe. Okay. So take note of those severity levels. So why do people start using in the first place? We have several risk factors. 1, social influence, right? Peer pressure. Antisocial behaviors in adolescence or early adulthood. So these are like defiant behaviors. When we say antisocial, we don't mean doesn't like people. well, let me rephrase that. When we say antisocial, that doesn't mean avoids people. Okay. Antisocial in my terminology, the way that we look at it, are behaviors that go against the general culture of society. So these are people that do like harmful things, but it makes them happy, right? So they're the kind of people that would sort of steal your purse and tell you to go fuck yourself and then run off with it or whatever. It'd bring them a sense of joy. These are people that would put firecrackers in mailboxes and set them on fire because it's for fun. Okay. So it's behaviors that kind of go against the general cultural norms at the time, right? Or that invade the personal rights of another person is probably a better way to put it. Okay. And these can start in adolescence or early adulthood. So it really stems from a lack of empathy. So when you start to see that lack of empathy or connection with another person, that's a risk factor. Okay. The societal parental perception regarding drug use. So if you have parents or a society that is generally like, it, if if you have very rigid parents, that can actually work opposite of you, going back to that original thing. But if you also have parents that are just permissive, so like if you see mom or dad having just like this giant bender, it can be normalized. All right. That can be something that's, oh, this is okay. Right. I used to do, when I was a baby therapist, not that I did therapies with babies, but a young therapist. Um, I did a speaking engagement for the DARE program, and it was in my hometown of southeastern Kentucky. And I said, how many, the kids are graduating from DARE, and the parents are there. And I said, how many of you parents want your kids to smoke? Raise your hand. And several raised their hand. And then I said, okay, put your hand down if you don't smoke at home. And that did not go well at all. I got a lot of groans, but I think I made my point that you don't want your kids to smoke, yet you're smoking. And I'm not trying to shame you. I'm just saying, like, maybe you can quit, right? One of the things we're seeing now with kids, and maybe you see it certainly on your college campus around you, is vaping, right? Vaping's pretty harmful, especially if they buy it off a Chinese knockoff website that you don't know where you got it, but it's cheap. Vaping's pretty harmful, to be honest with you. Long-term use of vaping can be pretty harmful. I understand that it's better than smoking, but there are other risk factors on top of that. And it's normalized. Like, this is just something that you do. This is part of being a teenager or being a young adult. So things to think about. Okay. What is the perception of our society or, a parental perception regarding use? If they're educated on really what this can be and the dangers of it, got a better success rate. Imagine that. Think about it with abstinence, right? Like every single one of us went through something during school about sex education, right? Some of us were basically told, don't do it. Now, how well has that worked for anyone? You're 15, 16, 17 years old. You're with your first boyfriend, girlfriend. You're alone for the first time. Now, come on. Come on. Come on. You're not going to be thinking about Mr. McGillicuddy standing in front of the class going, no kids, don't be having sex like that. We don't do that. That's not what that does not work. It doesn't work. However, what does work is educating and empowering those so that they can make healthy decisions. It has never worked to tell a teenager don't do something. And I've got a 12-year-old. Almost 12-year-old. If I tell her don't do something, I could say don't jump off that roof, and she's going to figure out how to lift the ladder and get up there. I mean, that's how we are as humans. That's not a shame thing. That's a human thing. Okay. Related, knowing adults or others who use, and then attitudes or beliefs towards substance use. Right. So again, if we have a healthy outlook on some of this stuff, it can lead to such better outcomes in terms of empowering kids and empowering people on how to best address some of this stuff. Also, ACEs, adverse childhood events. So there are 10 of them. The more you have, the greater likelihood someone's going to struggle with addiction. Okay. So physical, emotional, or sexual abuse, physical, emotional neglect, and then these various household dysfunctions. Okay. So these are big risk factors. Adverse childhood events, ACEs. Okay. Other things that could come from ACEs: lack of physical activity, severe obesity, diabetes, strokes. Yeah, so just like look at all of these things that are directly correlated with a high ACE score. So these are just things to be aware of as we're doing some of this work. It's not just going to be about morals. There's other things that go into it. We need to have respect for a person's past because their past is in their present. Here are some protective factors: strong sanctions or threats. That does seem to work, right? So strong sanctions for it. Parents or caretakers who are used as social supports. So having that good connection with a parent or a caretaker. Again, empowering. If you're working with teenagers, you're also working with the parents, right? I can't tell you the number of times I worked with teenagers for a while, that specifically substance use. And the hard part was I'm talking about all of these good things, and then they go right back into the environment with a permissive parenting group that is using. And so there's, I'm telling them this is not great, but their safety and their social support is saying, no, it's okay. So what am I supposed to do with it? So if you're working with kids, you're also working with the parents. So always keep that in mind. Getting them committed to school or educational pursuits, things that build their self-esteem and self-confidence. Certainly devotion to religion or any kind of religiosity or spirituality can help. And then 2 or more extracurricular activities. Now, this is mainly focusing on kids, teenagers, young adults, but this is also true for adults. The more activities, the more of a community that you surround someone with, the better likelihood that it can protect them from substance use or substance use disorders. Okay. So now we're going to get into a little bit of the nitty gritty as to what goes on in our brain. Okay. So think about this concept called hedonism. Okay. So hedonism is a school of thought that argues seeking pleasure and avoiding suffering are the only components of well-being. Our brain does a cost-benefit analysis. Look at literally any invention that has been created, and it is designed to lower the amount of work that we do. So, mowing our grass. I have a lawnmower. Many of you do too. Do you know what we used before that? We used a version of a lawnmower that was just a trimmer, like a clipper. It was like blades on a rotating, on a rotating, it's like a push mower, but it was just blades. There was no engine, there was no whatever. And so you just pushed it and it would cut the grass. Before that, we used a giant, like curved blade. It's called a scythe. And they would just, and that's a lot of work. We don't like that. So what if we could do something that made it a lot easier? Or we just buy a whole bunch of goats or cows and let them eat the grass. But outside of that, we'd have these giant curved blades and we would, but that's really hard and we don't like that. So we want to make it easier. So our brains are going to be searching for literally anything that's going to make things easy. Many of you have already started the process of figuring out how you're going to use ChatGPT to answer some of these questions that you're going to have to face. That's hedonism, right? If I can get the thing that I need without a lot of work, I like that. And that's not exclusive to this. Work is hard. It sucks, right? But we do it because there's other rewards. But if we could make it easier, boy, I would love that. Right? Because again, we do this cost benefit analysis of how can we get maximum pleasure with the least amount of work, right? How can we get the best grade with the least amount of effort? It's always a cost benefit analysis. And that's not to shame people. That's our brain, right? Because our brain wants to keep what's called homeostasis. And when we work hard, our brain our body reacts to that. I enjoy running, but if we're being honest, I don't enjoy running because my brain will tell me a bunch. Why are we running? Like it's hot. But if I decide to go do it, my brain wants homeostasis, right? So what do I do to balance that out? I sweat, right? To keep my core body temperature down. So until if I overheat, then everything shuts down because our body wants to get to homeostasis, right? So, Hedonism is actually a thing where people just go and it's nothing but just pleasure, right? It's, I don't, you let yourself go and imagine what that is, and it is what it sounds like it is. Okay. That's an actual thing where people go. So that's how our brains are wired. And that's not a shame thing. We like, we like to get those boosts of energy, right? If we had it our way, I mean, wouldn't you just want to eat chocolate all the time or sweet things? I'm a birthday cake person. I would love to go and to be fair, this is how you know that you're an adult, okay? Right now, I could stop this lecture at 35 minutes and 17 seconds, 6:49 p.m. on Tuesday, August 19th. And I could stop this and I could get in my car and I could go to Kroger and I could buy a birthday cake. It's not even my birthday. And I could eat the whole thing if I wanted to. I can do it and you can too. You don't need a reason. It doesn't have to be somebody's birthday to eat chocolate cake. Or I don't like chocolate cake, but like vanilla cake. Give me the vanilla cake with confetti, sprinkles, and ice cream, and I'm the happiest person in the world. And I could do that. I don't have to give anybody an excuse. I could just do it. I could I could just eat in the store. I could go and I get it and I can and do the beep, and then I could get a fork and I could just stand there and stare at Janet that's been working at Kroger for the last 15 years. And she wants to do more with her life, but she can't figure out what to do just yet. So she's kind of stuck, but she's kind of miserable, but she does enjoy her job because she enjoys the customers that she's working with. And I could stare at Janet and I could say, Janet, I'm going to eat this birthday cake. And she would say, sir, please don't, and leave, because you're making the other customers uncomfortable. And I would stand there and I would stare at Janet and I would eat that cake and it would be amazing. Right? You could do that too, because I'm sure you have your own Janet at your local Kroger. But ultimately, we will go to great lengths to avoid pain. Okay? And here are the types of pain: physical pain, psychological pain, emotional pain, spiritual or religious pain, past traumas. So when I'm working with someone, I'm not going to ask them, why do you struggle with addiction? Or why are you addicted? I'm going to ask them, why are you in pain? Because ultimately that's what it is that addiction is a way to cope with the pain. The addiction's a symptom. The pain is the real thing that they're in. So instead of asking why the addiction, ask, why are they in pain? Why are they hurting? And then that can lead you to why they struggle with addiction. Okay? Obviously, physical pain. If I'm in withdrawal or if I hurt, I'm going to use, because I want to be out of pain. If I've got anxiety or I'm struggling with depression or I'm worried all the time and I need to quiet that down, psychological pain. If I've got emotions, I've got these crazy emotions that are coming up at all times, pain. If I'm dealing with some kind of spiritual or religious trauma, pain. Why, God, why are you putting me through this? Why is this happening to me? I'm going to want to get out of that. Or even traumas in the past that I'm struggling with. Okay. And in many ways, it's a Skinner box, right? So we look at, so this is based on behaviorist B.F. Skinner. You probably heard that name before. You probably understand fundamentally what a Skinner box is. The mouse would hit the lever and would get the reward, right? And so when sometimes it would start out just hit the lever, get the reward, right? Hit the lever, get the reward. And that would come out in like pretty consistent, right? It was a consistent thing. Then they electrified the grid. And what they found was that the mouse would hit the lever more to get the reward over time because it helped them to be out of pain. So they noticed that pain would actually increase the response to get the thing because it helped them. It was something that was comforting, was soothing. They would kind of panic and then they'd start, and okay, I can focus on this instead of the pain that I'm in. That's addiction. It's addiction, right? But We all struggle with it. So let's talk about the reinforcement problem. All of you at some point have downloaded a game called Candy Crush Saga or a derivative of that. If you have not downloaded this specific one, it is the game where you match 3 jellies, right? So let's talk about how those games are set up because it's very specific in the way that they do it. So when you first start out, you have to match 3 jellies. Now you can see here where you can actually match 4. So there's like here you could switch these 2 and match 4. There'd be other combinations where you could match 5, or you could like do like they cross together in certain ways. And so basically what it does is the first few levels make it to where you're like the greatest player of all time, right? So you get all 3 stars, you get it done in like 2 moves somehow because you're so good at the game, and there's explosions and there's fireworks and there's, oh, you're the best and you're the greatest Candy Crush and you're the highest score. Connect to Facebook and tell everybody how great you are because we really care about your Candy Crush score. I don't have Facebook, so I don't know, but people really care about that. Connect with your friends and let them know how great you are, and blah 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 blah, and it just goes over and over and over, and like you're the best, you're the best, you're the best, you're the best, and so then eventually, so you get 3 stars, you're the best, connect to Facebook, you're the greatest Candy Crush player that's ever existed, and then you get the lollipop hammer. Oh boy, the lollipop hammer comes and it's a booster. It's a bonus, and you got it for free. And so you get to a point in which, like, the games are set up at, like this one specifically is set up in 15 level chunks, or 10 to 15 level chunks. And like the first few levels are incredibly easy, but then you get to the end, you get to like 8, 9, 10, and it's set up to where you are like 1 move away or 2 moves away. Okay. And that's where the lollipop hammer comes into play. And it was given to you for free. And lo and behold, not only does the lollipop hammer help you beat the level, but you beat it with a record score. And everyone is proud of you. And everyone loves you, right? And you're the best and you're the greatest. And your kids love you more because you've done, and oh my gosh, it's the lollipop hammer. I've done so much. And oh my gosh, and now I'm at the end. And now I've got to, wait a minute. I got to pay for this now? Well, I mean, I do need to progress in the game because now I'm hooked because I'm so good at it. It's played on all these things in my brain that tell me I'm great. Shit. All right, well, there you go. So we buy it. Best deal. One of these is best value. There it is. Luscious bundle. The best value, which is oddly enough the most expensive value. Okay. But it's a compulsion loop, right? I play a lot of video games. And it's this same loop. So there's the anticipation, right? Then I have the challenge. Then I get the reward. Then there's the anticipation of more. But in order to get that, I have to kill the monsters, and then I get the reward. And every time I do this loop, I'm releasing dopamine. Every time you match something, you release dopamine. Every time you get the reward and the high score, that's a release of dopamine. Okay, that neurotransmitter, the feel-good neurotransmitter in your brain. But that only counts in video games, right? It is not applicable to any other part of life except all other parts of life. It's everywhere. That loop is everywhere, right? So when we look at someone that's struggling with addiction, we have a tendency to not look at the other ways in which we are addicted. How many hours do you spend on TikTok? You don't have to answer that to me because I can't tell what you're saying, but think about it to yourself. How many hours do you spend on social media? Furthermore, what's your attention span like? And why do you think that is? I can only speak for me. I can't speak for you. But I have noticed that I have a really difficult time sitting and being still. Like, I went to the movies the other day and I watched, it just came out, Weapons. And it was good. But what I noticed is that every time there was a lull in the action, like they had like a in between going from one scene to the next, I would instinctively, and I didn't even think about this, but I would feel the impulse to reach over for my phone, which is in the seat next to me. And why am I doing that? I am engaged in it, but I can't. My brain goes, wait a minute, we're bored. We don't like this. So we reach for something. Think about that. Phones have changed our brains to where we're having a hard time paying attention to anything. Those of you that are 18, 20, 22, 24, I'm going to be real interested to see how you do working, because you're already kind of getting shit on it. I'm sorry about that. But and I'm not trying to lump all of you into this thing. I'm just saying it's the reality. Like our phone has only been the phones that we have now have been around for 15 years, right? We've had smartphones or whatever, but like the iPhone, which kind of changed the game to a certain degree and made it kind of, gotta have an iPhone, was 2009, right? And then we got like apps. And the apps are really what's kind of got us in this space. But like, how many of you are checkers on your phone? Like you have to check, see if you got messages. How many of you, like when you get, how many of your notifications are turned on? Every time you get a notification, it dopamine, right? And it's striking. Try to go a day without your phone. Now, some of you may say, oh, well, that's easy to do all the time. But for some of you, that could be like the most difficult thing. That's the brain. That's addiction. Now you know, but yours is a process, not a substance. Okay. The Kroger Plus card, right? That's set up as a loop. You buy stuff, you get gas points, right? TikTok. Again, how much do you spend on TikTok? Watching what? Some stuff's interesting, but like, how many get ready with me videos do you really need to watch? Right? Rewards, right? Netflix, the algorithm, Spotify, this dopamine pump that we're always getting. And it's curated for us. TikTok's curated for us. And I'm not saying all of this to say that this is bad. I'm just saying this is human. This is what we're facing. This is how our brains are changing in real time. And we don't always even be conscious of it. But these things are making it to where we can't sit with like a little bit of boredom. That's our brain changing. That's addiction. That's what happens. Okay. So I'm just kind of connecting it back to you a little bit. A few more things to think about. If you've got acute versus chronic, acute meaning severe and sudden in onset, chronic meaning it's developing and worsening over time. Do we treat it differently? How so? Okay. And then finally, just in summary, substance use disorder is a multifactorial problem. There is no singular root cause. And in general, it's a series of reinforced behavior patterns which are ingrained over time. And it's also very important to approach this as a public health issue. This is not a moral failing. It's not something that they've done wrong. We don't have to treat it with guilt and shame. It's a public health issue, and we should treat it as such. As always, Canadian geese are definitive proof that evil exists. Live mahalo. I'll see you next week for my favorite lecture. I love the lecture that we're going to do next week. Bye.